Good morning to all of you. Uh, for what happened yesterday, there was a problem in the internet connection. So we will discuss today about dermatological manifestations of systemic diseases and also tumors. So there are two vast topics again today. Um, so in dermatological manifestations of systemic disease. So these are frequently encountered in the practice of medicine. Now it is not in the dermatology unit, but in any discipline you may see certain dermatological manifestations which may involve the systemic diseases. And it may be the initial sign of an internal disease. Sometimes, for example, diabetic patient may come with balanitis, unknown diabetic patient, something like that. So there are so common examples and even rarer examples are there. And disease can affect skin as well as internal organs as well. So that is another aspect. So something like SLE, there are cutaneous manifestations as well as internal organ involvement. And also sometimes the treatment, so the systemic treatment given for the systemic diseases can complicate with skin drug eruptions, etc. And sometimes the drugs which we use can have systemic effects. So there are many facets of this topic. That's the dermatological manifestation of systemic disease. So now, actually, it is a very vast area. I have selected particular areas so that you can have a list of manifestations. So one is cutaneous conditions such as rheumatoid arthritis. So that is one disease. There are particular skin manifestations. Rheumatoid nodules. So they are inflammatory nodules, granulomas under the skin, which commonly occurs over the joints. And so they are a bit of hard, but they are not visible in the X-rays. So there are osteophytes, etc., which can mimic them. So then it will be visible in the X-ray. Then pyoderma gangrenosum, we will be talking a little in detail later. There are certain other dermatoses with neutrophilic infiltrate. For example, rheumatoid neutrophilic dermatitis. Then Sweet syndrome can be associated with rheumatoid arthritis, and there are so many other associations. So we'll be talking about that as well. Then vasculitis may be part of the rheumatoid arthritis as well. Then leg ulcers occurring in Felty syndrome, and also the paniculitis, that is inflammation of the paniculus, that is the subcutaneous fat, which may present as subcutaneous nodules. So in this picture, I think you can see that there is very angry looking ulcer, which has appeared over a short period. And the important features are this erythema or very red inflamed base, and also the edge which is elevated and having a bluish discoloration. So those are typical features of pyoderma gangrenosum. So pyoderma gangrenosum is occurring on the shins in this picture. So that's one of the typical sites, but can occur in other places as well. And it has these features: rapidly enlarging, very painful. So it is a neutrophilic dermatosis. So the main inflammatory cell infiltrating these tissues are neutrophils. It can affect both sexes and more common in those aged above 50 years. So these are the associations. So in internal disease association, inflammatory bowel disease, that is ulcerative colitis and Crohn's disease, rheumatoid arthritis, and the blood dyscrasias, including leukemias and other myeloid blood dyscrasias, monoclonal hemopathies, chronic active hepatitis, then dermatomyositis, polyangiitis, the vaginal disease, miscellaneous less common associations are there, which are being reported. Anyway, about half of the patients have none of the associated risk diseases. So it can occur without any underlying association as well. Then we move on to Sweet syndrome. The descriptive name is acute febrile neutrophilic dermatosis. So it describes the features. It's febrile disease and neutrophilic leukocytosis will be there with high ESR, and they will have tiredness and malaise constitutional symptoms with skin lesions. They can have other surface involved like sore eyes, mouth ulcers, joint involvement, headache. Sometimes other organs are affected, including the bone, nervous system, kidneys and intestines, liver, heart, lungs, etc. So these are the typical pictures of Sweet syndrome, where you get erythematous plaque lesion. It is juicy appearance. It's very sort of shiny or juicy appearance. So that is due to the edema of the epidermis and the dermis. So this is lesion due to the neutrophilic infiltrate. So this is a typical site, upper back, but it can occur in other places as well. Maybe one lesion, couple of lesions, and many lesions as well. So, so these are the associations. So mostly idiopathic, but we have to keep in our mind that it can be associated with underlying or something which may manifest later, myeloproliferative disorders, solid tumors, inflammatory bowel disease, rheumatoid arthritis, celi-based disease, as sometimes after infections, post-infections. Then another set of skin manifestations are paraneoplastic dermatosis. They are not so common, but they are important manifestations. Now, under these, we have several manifestations. One commonly mentioned one is acanthosis nigricans. But I should emphasize that acanthosis nigricans is very common, mainly due to obesity. So it is, when you see a patient with acanthosis nigricans, don't think that all of them are having underlying malignancy. So obesity, insulin resistance, metabolic syndrome, all are associated with acanthosis nigricans. So the acanthosis is rapid onset of hyperpigmented velvety changes over the skin folds, like neck, axilla, and groins. So when it is associated with malignancy, the lips, oral mucosa, sometimes on the tongue, and also the palms are involved with bursitis and constitutional symptoms like weight loss. So the internal malignancy would be an adenocarcinoma of the stomach, GI or GU tracts, sometimes here, GI or GU tract. So this is an example who had acanthosis nigricans. It's a fair-skinned person. You can see on the back of the neck, velvety thickening. So very soft, velvety thickening. One common presentation is skin tags may occur with the acanthosis sites. Then in severe involvement, you may get this sort of pigmentation over the knuckles and the other areas as well. Then there are other paraneoplastic. I hope you understand this paraneoplastic word that indicates manifestation which occurs distant to the neoplasia. You have the malignancy, but it is not the malignancy spreading to skin, or it is not secondaries, secondary deposits. Neither of them, either direct spread or secondaries, but these are paraneoplastic. They are not directly the malignant condition spread into the skin, but the associated conditions sometimes may be due to hormonal changes due to malignancy, sometimes due to metabolic changes, sometimes due to cytokine changes due to the malignancy. So dermatomyositis, especially adult onset, not the childhood dermatomyositis can be a paraneoplastic manifestation more, I mean, in a majority of patients, in about 1/3 of patients. And the features would be heliotrope rash, that is violaceous purple color edema in the periorbital area. Then Gottron's papules, where they get violaceous reticulate network-like areas, papules over the knuckles. They are called Gottron's papules. Then photodistributed poikiloderma is where you get pigmentary changes, hypopigmentation, then vascular dilatation and skin atrophy. Then there are nail fold dilated capillary lobes. If you magnify and see, you can see them. And generalized pruritus, sometimes diffuse alopecia, which are common for the connective tissue diseases on the scalp. Then commonly ovarian, lung, breast, colorectal, and pancreatic carcinomas and non-Hodgkin lymphoma are the ones we have to keep in mind. Then exfoliative dermatitis or erythroderma may be associated with cutaneous T-cell lymphoma or occasionally with the systemic lymphoma or leukemia. So this cutaneous T-cell lymphomas are the group where the primary lymphocytic proliferation is on the skin. So this is the patient with heliotrope rash, again a dry skin person. So in our patients, this, I mean, pigment people, it may not be very clearly visible like this. You can see the violaceous and bit of reticulate pattern due to the vasodilatation and also mild periorbital edema. So these changes are very subtle and sometimes may go unnoticed for weeks to months in some occasions. And these are the nail changes which occur with dermatomyositis. You can see the erythema of the nail folds with these black areas are due to the necrosis. The capillaries are dilated and some of them can get blocked. So these are blocked capillaries and ragged cuticle, because this cuticle is having poor blood supply. You can get unhealthy cuticles. So those are features in dermatomyositis. And there are several other conditions we call as paraneoplastic manifestations. Sign of lesser palate, that is appearance of multiple seborrheic keratosis over a short period, hundreds of seborrheic keratosis. We will be talking about seborrheic keratosis in the latter part of my lecture. So they may have other features like acanthosis and generalized pruritus. Tripe palms. So these are the velvety palms. So hyperkeratosis and hypertrophy of the epidermis causing this appearance. So can be associated with acanthosis nigricans as well. Erythema gyratum recurrens, that is as if you have cut across a tree, concentric rings, a rare manifestation of internal malignancies like bronchial carcinoma, etc. This is an example with the then carcinoid syndrome. Carcinoid syndrome will have flushing, erythema of the head and neck area, pellagra-like dermatitis, so they consume niacin, and scleroderma, that is tight skin occurring in the advanced disease. So carcinoid syndrome can have manifestations, and some internal malignancies can cause hyperkeratotic lesions called acrokeratosis paraneoplastica or Basic syndrome. So sometimes in the extremities like ear as well as in the external ear, etc. So diabetes mellitus, you know, it is a very common condition in Sri Lanka as well as in the other developed countries. So diabetes has so many skin manifestations. Again, acanthosis nigricans we described, commonly with insulin resistance. So when there is insulin resistance, there is a high level of insulin in the circulation. Insulin induces insulin-like growth factors which give rise to thickening of the epidermis. Acral erythema. So due to the changes in blood vessel tone control, so there is capillary dilatation, and so giving rise to erysipelas, like as if there is an infection. So there are patches of erythema over the hands and feet. Then diabetic cheiroarthropathy, these are due to the deposition of various substances in the ground material in the dermis, and which limits the mobility of the hands, the small joints of the fingers. So that is, there's a sign called prayer sign. Now you can see in this patient, due to the flexion, he can't get the fingers touching each other. So this is called prayer sign in diabetic cheiroarthropathy. And furthermore, diabetic dermopathy is much more common a manifestation, again due to microvascular changes causing some sort of necrosis in the area and bleeding. There are brown atrophic macules and sometimes depressed areas on the legs, possibly initially precipitated by trauma. There is a granulomatous condition called granuloma annulare, where they present with annular lesions with small papules at the border. So when it is disseminated, widespread and occurring in adults, that can be associated with diabetes. Eruptive xanthomas, xanthelasma is lipid deposition around the eyes. So xanthomas can occur in the limbs, etc., in the other areas. And so eruptive xanthomas are where there is rapid onset of xanthomas in the buttocks and sometimes over the extensive surfaces. Then again, it is associated with diabetes, sometimes dyslipidemias as well. Then hemochromatosis can cause pigmentation of the skin. So that is due to sometimes, rather than due to hemosiderin deposition, that is due to increased melanin synthesis. And in parallel, they will have cirrhosis due to liver involvement and cardiac dysfunction, in addition to diabetes, diabetes due to pancreatic involvement, cardiac dysfunction due to the myocardial involvement. So this is a patient with diabetic dermopathy. You can see many lesions in his shins, and then you can see the annular lesions. So in the previous picture, you can see the brownish color, sometimes atrophic lesions. And shins are the common site for diabetic dermopathy. So when you see similar picture, just check whether he's a diabetic. These are the granuloma annulare, where you get this annular ring-like lesion without any epidermal changes. Epidermal changes are the scaling or vesicles are not there because epidermis is intact, but the granulomas in the subepidermal, the dermal region. So sometimes they are not symptomatic, sometimes can be itchy, and it is widespread and occurring in adults. We think about diabetes. So this is a picture of eruptive xanthoma. This is elbow. You can see the yellowish color in addition to the skin color, so indicating that lipid deposition over there. Necrobiosis lipoidica diabeticorum. So the word describes the background. Necrobiosis, that is destruction of the fat layer. Then it occurs over the chins, and you can see the atrophic areas, yellowish areas, because of the epidermis is thinned out, and sometimes it can ulcerate. You can see the yellowish color here, and atrophic skin and ulcerated areas. So you see that there are so many further associations of diabetes with skin. Then neuropathic leg ulcers. So with the peripheral neuropathy occurring in long-term diabetics, they can have neuropathic ulcers. Then this perforating dermatosis, that is, the patients describe there are papular lesions which are itchy, and when they scratch, there is a sort of a tiny dot-like thing coming out. So that is keratin. So those are called perforating. That is collagen and sorry, it is collagen. Collagen is extruded through the epidermis in these lesions. So perforating dermatosis, and so that is seen in chronic kidney disease associated with diabetes, often with diabetes and chronic kidney disease. Rubiosis, that is chronic flushed appearance of the face. Again, this can be due to poor diabetic control, and the dietary control will improve the condition. Then another relatively rare manifestation is scleroderma. So don't get confused with scleroderma, which is coming under autoimmune connectivity diseases. Scleroderma, or sometimes called adultorum of Buschke. Scleroderma of adultorum of Buschke. Erythematous induration of the upper back and the nape due to glycosaminoglycan deposition, similar to diabetic ketoarthropathy. So now we will move on to the other, this endocrine abnormality, which has many skin manifestations, thyroid disease. On the left-hand side of the slide, you get hyperthyroidism, and on the right, hypo. Hyper, you get fine, velvety, smooth skin. Hypo, there is dry, so that it is rough, coarse skin, and cold and pale because of the poor circulation. In hyper, it is warm and moist due to excessive sweating, and in hypo, it is yellowish discoloration as the carotid. Then pretubular myxedema can occur in hyperthyroidism with thyroid atrophy, where the nail fold changes, etc. occur, and pruritus and acquired icterosis and palmoplantar keratoderma can be features of hypothyroidism. Cushing syndrome again will have several skin manifestations. The moon face is fullness of the cheeks, then dorsal cervical vertebral fat deposition, so-called buffalo hump, pelvic girdle fat deposition, so they get truncal obesity, and thinning of the limbs, reduced fat in the arms and legs. So in Cushing syndrome, you get skin atrophy, leading to multiple striae, especially over the skin stretching areas like abdomen, flanks, arms, and thighs. Cutaneous fragility, giving rise to poor wound healing, and purpura with minor trauma due to the lack of collagen support, and cutaneous infection, and also less adnexal infections, etc. And also they can have corticosteroid-related acne and increased hair growth. So this is a patient who has extensive striae. And Addison's disease, again, that is something which may present to dermatologists with hyperpigmentation. So in primary adrenal failure, you know, there is increased ACTH levels. So ACTH has MSH, melanocyte stimulating hormone-like effect. So that is how they get hyperpigmentation. So it is diffuse, but more over the sun-exposed areas, sites of trauma, axillae, perineum, nipples, palmar creases, and also mucous membrane involvement is common in about 90% of patients. So they may have additional autoimmune, organ-specific autoimmune damage, vitiligo, and also chronic mucocutaneous candidiasis. Liver disease again will have so many skin manifestations. Like in cirrhosis, you can get this list of manifestations. Due to the hormonal effect, they have blood vessel dilatation because some of the hormones are not excreted, they are not metabolized due to the liver impairment. So that telangiectasias are common due to the same reason. Gynecomastia, sex hormones are retained. Then palmar erythema due to blood vessel dilatation, thyroid enlargement. Veins may be visible. There may be white nails and translucent bands. Sparse axillary and pubic hair due to again changes in sex hormones. Primary biliary cirrhosis will definitely have jaundice and diffuse hyperpigmentation, and also xanthomas can occur. So maybe eruptive, then plain xanthomas, and also tuberous that is associated with the tendon. Then the pruritus and scleroderma can be associated. Scleroderma can be associated with primary biliary cirrhosis. So in end-stage renal disease, again we get a lot of skin manifestations. Obviously, they look pale in color due to many reasons, low hemoglobin and certain pain products and dry skin. And cirrhosis and acquired icterosis can occur. So due to these factors, as well as retained metabolic material, they can get pruritus due to calcium changes. They can get pruritus. Then acquired perforating dermatosis, that the collagen is extruded through the skin. In pseudoporphyria, they are photosensitive and develop skin vesicles after exposure to sunlight. Calciphylaxis, that is calcium deposition in the vessels causing large areas of necrosis of the skin. And uremic frost, that is they excrete urea through the sweat so much so that there will be urea crystals depositing on the skin. So that is called uremic frost. So now we are moving on to our next part. Actually, I have discussed so many systemic manifestations. You may get skin manifestations in the due to systemic disease. Now, tumors. So there are so many tumors on the skin. Some of them are benign. Most of them are benign. Few of them are malignant. Some of them are very common. And melanocytic nevi. So nevi are genetically determined. So sometimes the misnomer birthmarks, but most of the melanocytic nevi are not there at birth. So there are melanocytic nevi or moles which are present from birth. They are called congenital melanocytic nevi, but the others are acquired during the teenage, mainly during the teenage. So then sometimes patients get confused when we say that they are birthmarks, so better to use the word moles. So it's very common. Probably you may have one or two, then circumscribed, acquired pigmented macules, papules or nodules. So group of melanocytic nevus. They can be located in the epidermis and the dermis, both in the between the epidermis and the dermis. So then we call it junctional, and sometimes they may gradually regress to the intradermal area. So dermal, epidermal junction. So they are called junctional. When invading the epidermis, we call them compound. So when they are in the junctional area, basement basal area, we call them junctional. Then when they invade, we call them compound nevi. Sometimes the melanocytic nevi will gradually become dermal. So then we call them dermal melanocytic nevi. So later on in the later life, there may be fibrosis, so they gradually regress. So this is a very good example for numerous melanocytic nevi. We don't see much in our skin, but in fair skin individuals, so this is a common sight having multiple melanocytic nevi. So these are a bit of enlarged versions. You can notice that they can be very dark in color. Sometimes they can be light brown, and so they can have different morphological appearances between enlarged and see. Now, when you have a melanocytic nevus, Sometimes patients are concerned whether they will become malignant lesions and whether there is one aspect, and sometimes they want them to be removed due to cosmetic reasons. So when somebody wants for cosmetic reasons, then most of the time we can go for excisions. But medically, these are the indications for you to consider excision of a melanocytic nevi. So if it is on the scalp and which does not have the classic appearance of a melanocytic nevus and mucous membrane and anogenital area, so better to get them excised as a prophylactic measure to prevent developing into malignancies. If there is a rapid change in size, rapid change means over a couple of weeks to months. If the color becomes not symmetrical, so there are different colors, sometimes high reduction in color, sometimes dark areas, etc. If the border becomes irregular and trying to encroach the normal area, if there is any erosions with itching, then pruritus, then in dermatoscopy is a gadget like ophthalmoscope where we can magnify certain things and see. We just look through it and we can magnify up to 10 times. So that helps to identify further features in the lesion. So if it shows certain changes, then we can consider removal of the melanocytic nevi. So another group of tumors are vascular tumors or vascular malformations. So vascular tumors are where the vascular endothelium proliferate. The example is hemangiomas, and they show endothelial hyperplasia, whereas malformations have a normal endothelial turnover, but they have malform. So they may be having larger vessels or sometimes numerous capillaries, etc. So hemangiomas have different features to malformations. Hemangiomas are usually not present at birth. Appear after a couple of months. Gradually they grow, and first year, maybe up to second year, that is proliferating phase, and undergo slow spontaneous regression during childhood. So it remains as a scar afterwards. So vascular malformations are errors of morphogenesis of the vasculature and occurring in the intrauterine life. Most are present at birth, and some do not appear until years later. So once they are there, they grow proportionately to the growth of the body, the child. Sometimes there may be some amount of enlargement, but not like in hemangiomas. In this picture, you can see hemangioma. So in a very active phase on the left-hand side, on the right side, you can see that it has regressed and leaving a scar tissue. So then again, in this child, you can see on the left-hand side, over the tip of the nose and lateral to the eye, to hemangiomas. Later on, they have regressed to the scars after about 2 or 3 years. Now here, what you see is pink or erythematous patch over the maxillary area, and so this is due to capillary malformation. So that's a type of, there can be arterial malformation, venous or arteriovenous malformation, lymphatic malformation, as well as capillary malformation. So called portwine stain. So this is portwine stain due to capillary malformation, present at birth and may remain afterwards. So then we will move on to another common condition called epidermoid cyst or sebaceous cyst. So most common cutaneous cyst derived from epidermis of the epithelium of the hair follicle and is formed by cystic enclosure of epithelium within the dermis. So there is keratin and sometimes the sebaceous discharge. So gradually it can enlarge. It is commonly over the face, neck and upper trunk, and sometimes in the scrotum. There may be multiple lesions. So dermal to subcutaneous nodule often connects with the surface by keratin-filled pores. So that is we see as a punctum. Now, seborrheic keratosis. We mentioned about this few minutes back about the Lacerta-led sign, where you get multiple seborrheic keratosis. So this is the most common benign epithelial tumor. It's so common and generally do not appear until age 30 and continue to occur over a lifetime. So they say about half of the population will have, 50% will have by the 50 years of age, at least one or two. It varies in extent from few scattered lesions to hundreds of lesions, mainly in the elderly. So from small, barely elevated papule to plaques with body surface and stuck on as if it is sort of pasted on the skin appearance. So cosmetic concern is the main thing, otherwise do not need treatment. So it can become irritated or inflamed due to trauma, causing pain. So in that occasion, we should consider squamous cell carcinoma as a differential diagnosis. In this patient, you can see flat, darker pigmented, velvety appearing seborrheic keratosis, large seborrheic keratosis. In this patient with this brown skin, you can see numerous seborrheic keratosis. Actually, if you observe when you are going along the road, you will see so many patients like this, so many people like this, having this pigmented, elevated plaques or flat top papules with soft texture. Syringomas. So they are again benign adenomas of the eccrine ducts. So there is adenoma, so that when the adenoma grows, the eccrine duct will be blocked and set will not come out, so that it will collect under the skin. So what happens is, it becomes a tiny papule under the skin, so visible as yellow firm papules that occur mostly in women. It begins after puberty. After that only the setting is more and can be familial as well. So gradually they will increase with time. So periorbital area is the commonest area, usually symmetrical, but also can involve eyelids, face, axillae, umbilicus, upper chest, and also vulvar region. So here you can see this yellowish or skin colored tiny papular lesions in the periorbital region. So typical appearance of syringoma. Dermatofibroma again is a common benign tumor, button-like dermal nodule, usually occurring on the extremities. It is important because of its cosmetic appearance, or it's being mistaken for other lesions such as malignant melanoma when it is pigmented. Rarely lesion can be tender. This is an example of dermatofibroma. You can see the brownish pigmentation, and it is attached to the epidermis, so that when you press from the surrounding area, there will be sort of depression, like a buttonhole appears. So then skin tags, very common. Soft skin colored or tan or brown, oval pedunculated papilloma, or we call them fibroepithelial polyp. So fibrous and epithelial tissue is there. Can have different sizes, asymptomatic, sometimes can become tender due to trauma or entanglement. Commonly in middle-aged and elderly, and in obese people, diabetic and obese people in tags are much more common. Often noted in interchangeous areas as well as where you have the friction. So here you can see in this patient acanthosis nigricans is there, so obviously she must be an obese person. And having these skin-colored pedunculated skin tags, there, skin tags or the fibroepithelial polyps. So actinic keratosis or solar keratosis is due to long-term sun exposure. So with the long-term sun exposure, there will be single or multiple dry, rough, scaly lesions with the background of sun damage. So they can be pre-malignant lesions leading to squamous cell carcinoma. Actinic keratosis are very much rare in pigmented races, but in fair skin individuals, it is much more common, especially over the exposed areas. You can see the sun damage with erythema, skin atrophy, and on top of that, you can see this hyperkeratotic pustular lesions. Some of them may be a little bit sore. Now we are from the benign tumors, we are gradually moving towards the malignant. So squamous cell carcinoma in situ, that is, it is still there in the, without breaching the basement membrane. So it has not encroached below the basement membrane. So they present as pink or red, sharply defined, scaly plaques in the skin. So we call it Bowen disease. Often induced by ultraviolet radiation or human papilloma viral infection. So those are factors which may predispose somebody for skin cancers. So we treat them with topical fluorouracil, sometimes imiquimod. I hope you have heard about imiquimod. That is an immune modulator, which induces our immune system to develop inflammation and then remove the tumor. Cryosurgery, where we apply liquid nitrogen in nitrogen in liquid form, very cool, to freeze the cells and damage the cells. CO2 laser evaporation, so laser treatment, where we can damage the tissues, or sometimes excision, and morph micrographic surgery. That's a method of doing excisions. You do exercise and immediately look under the microscope whether you have completely done it or then not. You go back to the patient and re-exercise. So this patch of Bowen's disease or carcinoma in situ, squamous cell carcinoma in situ, you can see on the left side, erythematous patch with a little bit of scaling. On the right side, you can see this erythematous patch with crusting. So typical appearance of Bowen's disease. Then squamous cell carcinoma proper one. So it's malignant tumor of keratinocytes, usually arise in the epidermal precancerous lesions. So in this actinic keratosis, these things can occur, or in the Bowen's lesions can become a squamous cell carcinoma. There again will be keratinization. So majority of ultraviolet induced lesions have low rate of distance passes. So it is not so spreading all over, but local damage will be there, but can go into the lymph nodes. So in more aggressive squamous cell carcinomas or immunosuppressed individuals, the metastasis can occur. Treatment is by surgical excision as well as radiotherapy locally over the lymph nodes. Now, here you can see a couple of squamous cell carcinomas, central crusting and a bit of necrosis with surrounding inflammatory erythema. And here you can see tumor-like growth, very much progressing squamous cell carcinoma. And here, a very destructive and very much progressed squamous cell carcinoma on the foot. The basal cell carcinoma. So that is the most common cancer in human. Luckily, it is not usually metastasizing, it is locally destructive. So caused by ultraviolet ray exposure long term. So there are genetic changes, PTC gene mutation in most cases. So clinically, these lesions can be nodular, ulcerating, pigmented, sclerosing, and superficial. So those are different clinical types of BCC depending on the features we see in the lesion. So it is locally invasive, aggressive, and destructive. So it will destruct the tissues. It is invasive and destruct the tissues, but slow growing, and there is very limited tendency to metastasize luckily. So otherwise, it is the most common cancer in humans. Treatment is surgical excision, then most micrographic surgery is to remove and see under the microscope whether you have taken everything out. If not, you immediately go back to the patient and who is on the theater table still, then remove further and see under the microscope. Electrodesiccation or electroporation can be done. Curettage, we can scrape it off with the curette, and liquid nitrogen can be used to treat and emit mode, especially for the flat variants. Can give us can remove the basal cell carcinoma, especially when we can't go for surgical and other measures. Now in this patient, this is typical side angle of the nose, and you can see the typical appearance, shiny surface, dilated capillaries. So there is one feature for basal cell carcinoma, dilated capillaries, and it is much more visible on the left-hand side picture, and sort of pearl-like appearance at the border. And even here you can see tiny papular elevated border here. Erythema and inflammation with dilated capillaries. Angle of eye. Again, you can see this string of pearls appearance over the border, and central ulceration, necrotic area. Again here, the central ulceration. Now, here you can see the sclerostomorphic BCC where there is atrophy, like morphia-like BCC, but typical elevated beaded-like appearance is seen here. So, if untreated, it will gradually encroach the eye and damage the eyeball as well. Cutaneous melanoma. That's the most malignant tumor of the skin. So this is the most malignant tumor of the skin, so which can kill patients if not detected at the early stages. So it arises from the malignant transformation of melanocytes at the dermal junction, and or from the melanocytes or dysplastic melanocytic nevi. So it may occur over initial mole or a nevi, or congenital melanocytic nevi, or otherwise can occur without any background nevi. So become invasive and metastasize after various time intervals. Then 6 signs of melanoma. So when we want to see whether a melanocytic lesion is malignant, so these are the features to decide. So there are melanocytic nevi, then with the change, so then we need to see whether it is a malignant melanoma. So then we have to go for excisions quickly and take precautions. So asymmetry in shape. So this is called ABCDE. So sometimes some use ABCD only. Asymmetry in shape, one half unlike the other. Usually moles have symmetry. So when you, and sometimes when a mole which has a symmetry changes its symmetry, then it is highly suggestive. So one half is unlike the other half. Border is irregular. So all of a sudden the border is trying to encroach into the normal area. Irregularly scalloped, notched. Then the color is not uniform. So some areas are mottled, some areas are dark, some areas light brown, sometimes depigmented, etc. So different colors is another indication. Diameter is usually large, greater, if it is more than 6 millimeters. Then again, it is a factor we have to think whether it is a melanoma. Then the D, some use D for ugly duckling sign. That is, now actually, luckily we don't have much melanomas because we are protected with melanin. So that is another major advantage of pigmented skin. So people in societies where they don't have skin pigmentation, and especially if they are exposed to sunlight, then they have a high chance of developing malignant melanoma. So they have numerous moles as well as freckles or lentigens. So then how to identify this change in moles? You can't go on exercising all these 50 to 100 lesions. So you have to detect the abnormal one early. So they have special melanoma clinics or mole clinics where every 1 year they go and check with the previous photographs and try to identify any change in mole. So ugly duckling. So when there is a group of ducklings, if there is one with abnormality, you can detect that one. So that is called this ugly duckling sign. So you always compare with the all set of nevi in the same vicinity and try to detect the abnormally behaving one. Then elevation is sort of, it's always an elevated lesion, but when there is irregular elevation, surface distortion is assessed by the side lighting. When you flash the light in an angle, you will see these changes in elevation. Some of others use E for enlargement, a history of an increasing size of lesion. It's one of the most important signs of malignant melanoma, rapid enlargement. So you can see some clinical pictures here. You can see this area is this is a flat lesion, sometimes we call lentigo maligna melanoma. There are certain darker areas compared to the other areas. So, and irregular projections like trying to spread. And here again, you can see the two colors, the darker ones. And here it is lighter color, but here it is dark color. And of course, in pseudopodia. And again, you can see the asymmetry of the color. So here, very dark areas are there, light areas are there, and irregular border. And here you can see a tumor, probably the melanoma here, as well as a large, widely spread lesion over here with different colors and hyperkeratosis as well. So in this picture again, you can see the color change and pseudopodia formation asymmetry. And so if elevation also asymmetrical, here again pseudopodia formation, and here you can see regression in the center. Sometimes fibrosis due to the different changes and light lesions. This is spreading, and this very dark color with central, even now central bluish color is another feature. And here you can see surgical excision done for melanoma and recurrence over the side. So they can spread into the lymph nodes. So this is what has happened here. So the lymph nodes are involved and then they become ulcerated and perforate. And surgical excision with wide local excision with or without lymph node excision. So that depends on the spread of the melanoma. So other modalities are there. So interlesional therapy with chemotherapy and immunotherapy where there is immune modulation to remove the malignant cells, signal transduction inhibitors, chemotherapy, palliative local therapy, etc. So that's the end of my lecture today. Wish you all the best.